help the public, policy, as well as program managers understand disease issues surrounding the country. We'll start by introducing ourselves to each other. So I would like to start with the participants, and then I will introduce you to the panelists. We can start with my immediate right. Please tell us your name and where you're coming from.
I'm Steve Chombo from Radio Maria.
Good morning. My name is Edith Zulu from One Radio.
Good morning. My name is Delia Chaya. I'm from Sanis.
Good morning. My name is Judith Mwape. I'm from 5FM News Radio.
Good morning. My name is Christine Mapani. I'm from Crown TV.
I'm Mike Escabengo from Sanis.
Good morning. I'm Susan Lungo from United Voice Radio Station.
Good morning. I'm John Cho from FCS.
Good morning. I'm Mabel Knight from the BBC Radio 2.
Good morning. Good morning. Maeza Chinama with Radio Phoenix.
Good morning. My name is Joy Kasakala from Millennium Radio.
Good morning. My name is Esmat Sikaso from Hope Channel Zambia, the SCA TV station.
Thank you very much. It's a pleasure meeting all of you. Allow me to introduce my panelists. Next to me here, we have Dr. Duncan Chanda. He's an infectious disease specialist at UTH. He wears a lot of hats, including being supervisors to many postgraduate students and so on and so forth. It's a big CV. I can't take you through it today, but I'm sure you can find space to chat with him on it. Next to him, in absentia, is Mr. Mpanga Kasonde. He will be joining us soon. I think he stepped out, but he'll be joining us soon. He's a senior laboratory scientist at the Zambia National Public Health Reference Laboratory. Then we have Ms. Malungo Mayovwe. She's a specialist in the vaccine area. And so all the questions that you have around vaccines, she'll be able to tackle. But she too wears a lot of hats in the public health sector. Then we have Dr. Dalal Naim, who is our mental health specialist, also at the Zambia National Public Health Institute. He also carries a lot of experience around mental health and research, and he's been quite helpful in keeping us aboard, especially in this pandemic era. I hope you enjoy this media cafe. And the procedure is that I will leave with some questions and allow the panelists to speak into the issues of COVID. Our theme for this cafe is current COVID-19 situation. Should we be concerned? There have been a lot of questions, there have been a lot of rumors, there have been a lot of false information, and there's also been true information that has been going around. But we want to ensure that we have the correct information. Like I said earlier on as we spoke, be our ears, eyes, and mouth piece in terms of public health and many other issues. And so we rely on you. And because we rely on you, we thought it to be important for you to have up-to-date information on the current COVID-19 situation. My name is Matianga Masawaliwewe. I'm the Director of Communication, Information and Research at the Zambia National Public Health Institute. I have a background of virology and epidemiology, but my strength now, or my area now of focus, is communication. So, there have been a lot of arguments. My panelists here. Oh, so Mr. Mpanga is back. Thank you, Mr. Mpanga, for joining us. There have been a lot of issues First of all, we've seen a rise in the number of cases or the incidence of COVID-19, across the country. And we've also seen an increase in the number of people being hospitalized due to COVID-19. And so there's a lot of worry in the public, but there's also disbelief in the public. And so we thought it would be important to have you here to give us the true scenario. What is the real situation? You are the experts in the area, and we are sure that you will give us the true information. So I'll start with Dr. Chanda Duncan. Should we really be concerned about the situation?
Good morning. Thank you for having me here. As introduced, I'm Duncan Chanda. I'm the infectious disease physician working from University and Hospital, and I direct the infectious disease center there. We are primarily also responsible for outpatients COVID management and testing for outpatients. So should we be worried? In a sense, yes. Like every other disease, we should be worried. And especially that COVID is contagious. And again, knowing that it actually affects people who are older and people with comorbidities. We have seen, this is probably the fifth wave of COVID, or fifth or sixth, somewhere there. But I think we have seen the epidemic evolve from moderate disease in the first wave, second wave became severe, third wave we had very high mortalities before the variants changed to Omicron, whereupon it stabilized in terms of mortalities. So in the current wave, I'm sure I'll speak to this, we still have a mildly virulent strain going around. Most of the patients actually are presenting with flu-like symptoms, not so specific as respiratory, usually upper respiratory symptoms, a little bit of sneezing, headache, maybe low-grade fever. And these symptoms, for the majority of the patients without any comorbidities, they tend to settle down. But we should worry mostly for those people who are ill, people with cardiac conditions, people with diabetes, elderly people, because the clinical course can actually change for the worse. So we should be worried, and we should actually take the necessary precautions not to get infected, and also not to pass on the infection to the high-risk population. Yes, I think that's what I'll hold back there. Yes.
Thank you very much, Dr. Duncan, for that important piece of information. So as you indicated, we would like Mr. Panga, who is our senior lab scientist, to just talk to us about the issue of mutations. There's been a lot of outdated false, but we need to clarify. There's been a lot of information, across, especially the social media platforms, that we have a big mutation, and this new mutant or new variant is causing catastrophe, among the members of the population. Just give us an insight on that.
Thank you very much. You call it a rumor that the SARS-CoV-2 is mutating. It's actually not a rumor, because ladies and gentlemen, the SARS-CoV-2 indeed does mutate for it to survive. So and this is what we've had from the beginning. I'm sure all of us do remember it started off as the nCoV 2019. It went into the alpha, the famous one which really ravaged us was the Delta. And obviously, we all know that we had the Omicron and we still have the Omicron. So it's not a rumor that the SARS-CoV-2 virus is actually mutating, because that is what it does for it to survive. And there's several reasons for that. That, we have a lot of interventions that we're using in terms of prevention of disease. Now we have vaccines. We now have, antivirals for the same. So for the virus itself to survive, it obviously has to find ways and means of surviving through all these various interventions for prevention that we're doing. So it's not a rumor that SARS-CoV-2 is mutating. It is true that it is mutating. But what is not correct is that there is now a new, you call it new mutant it's called mutant? Yeah, new mutant of the virus that we currently have that's, very, very aggressive and all that. No. So that is what is not true. But we still have the same variant that we had, which is the Omicron variant. It hasn't mutated to become more aggressive than we've had before. If anything, we could say it has mutated to become less aggressive. So we have the mutations, and we have been tracking these mutations and how the virus has been changing over time. And we keep monitoring how it is changing in different parts of the country. We have a system that detects these mutations in almost real time as the cases are coming up. So it's not that the virus has mutated to become more aggressive. That's not true. But indeed, the mutations are normal for every virus for it to survive. And not only for COVID, but several other viruses, they do undergo mutations. So it's a normal process. And the only comfort that we have is that we have systems in place that are able to, for us to be able to detect any change in the virus and be able to know that, it has mutated to become this. And obviously then we have, again, systems that help us also to, track and monitor in terms of, how the patients are presenting, just like Dr. Chandler did mention. So that is the position. Thank you.
Thank you very much, Mr. Panga. Just to settle us down, would you like to tell us what variant is actually circulating?
Right. So we I think from the variants perspective, and then for all of us here, I will tell us that the current, variants that we have is the Omicron variant. But obviously, for those of us who are more closer to the details of this, we have, within that group of the Omicron, we've had several different variants of the Omicron. And the latest one that we currently have is the XBB.1.16. I'm sure you remember previously we had the XBB itself. It changed to XBB.1.5. Now we have XBB.1.16. That is the current strain that we have. But generally, it's still the Omicron, variant that we currently have. So I'm sure if you do remember previously, before the Omicron, we had the Delta variant, and then after the Delta came the Omicron. But then within the Omicron itself, we've had several other single mutations, but still the Omicron. But there are sub variants that are within there, and of which currently what we are reporting now is a mix of the XBB 1.5 and also XBB.1.6.
Thank you very much for that scientific mind, Mr. Mpanga. Let's go into the issues of testing. What is the protocol now? What is the policy on testing? Can I just walk in and say I'm feeling COVID-like, can I be tested? Or I was sitting next to somebody with COVID, can I be tested? What is available and what is in protocol?
Thank you very much. So the government has really, obviously with partner support, has built quite a lot of strength and systems in terms of ensuring that testing is made available and provided as close to the people as possible. And in all the facilities that are out there that we have under the Ministry of Health and many others, there is actually testing available that is there. And in terms of the target for us, anyone who feels, flu-like symptoms and they feel unwell are actually free to go into any of the health facilities, and testing is being done from there. And so there's really no need to panic. Walk into any health facility, and testing services are actually available in these facilities.
Thank you very much, Mr. Mpanga. Let me get back to Dr. Chanda. Doc, I've heard from some family members and friends, and even just in the social media platforms, of people having flu-like symptoms, tested for COVID, it's negative to COVID, but they feel this is really COVID-like because some of them have already experienced COVID before, and they're like, these symptoms are definitely COVID, but the test came out negative. Are we experiencing a different disease, or is it that people have gained some kind of immunity, and so it's not obvious to see this, see it in the test? Or
it's a different season as well. It could be any other respiratory virus, or it could be a bacterial infection, but really mostly it's the viruses. And coming to COVID, the positivity really has to do with the timing, from the time symptomatically. Unless really the doctor has very strong reason to say this is COVID. Yeah, so that is going to be quite a common happening as the virus actually evolves. Because predominantly right now, we're not seeing lower respiratory tract infection. As a matter of fact, I haven't admitted anyone to ICU for some time due to COVID, purely due to COVID. The scenario we get is for someone with another comorbidity, and they come in the hospital because of that. So from the outpatients, those people at home, and you have flu-like symptoms, you can leave them through, unless you have a really good reason to go and test. If you come and test, it's positive that two things. If you're a high-risk patient, actually if you're high risk, you have got any comorbidities. Even when you have that flu-like infection, you should present for a test. But if you're relatively young, no comorbidities, I hope everyone understands when I'm saying comorbidities, right?
You could explain.
Another medical condition such as diabetes, hypertension, cancer, HIV, tuberculosis, asthma. Those will be comorbidities. Okay. So if someone is at high risk, consider those people at high risk, even when they have a flu-like infection, they're encouraged to test, because when they're positive, we've got some antivirals to give orally on an outpatient basis. I know that previously the only antivirals we had were actually OIV antivirals, but then we have moved on to that. So yes, people should do the test. And if it comes out negative, you probably have another virus, okay, another viral infection. I'm sure all of us, from our experience, we know around the cold season, we tend to have colds. And what are colds most is just viral infections, which are limited to the upper respiratory tract infection, to the upper respiratory tract. So yes, it can come out negative, and it may not be COVID, even if you really feel like COVID. Influenza really gives you the same symptoms as COVID. Yeah. And actually, it can actually go to the lower lungs, and you can really feel bad about that. Yeah. I think, yeah, that would be.
Thank you so much, Dr. Chandler, for just reassuring us that we are able to pick and determine what is actually wrong with you. And so it is important to go to the healthcare facility so that we know what is exactly wrong with you and treat you accordingly. But Mr. Mpanga, before I go to the other panelists, do we have the capacity in the country to determine the cause of other respiratory illnesses? So I heard Dr. Chanda talk about influenza and other viral infections. Do we have that capacity?
Yes, indeed. We have the capacity to actually do detect any other the respiratory infections. Dr. Chanda has mentioned, a variety of them, that we have viral respiratory infections, we have bacterial respiratory infections, and yes, indeed, we have this capacity. And then obviously, I can also take this opportunity just to indicate that it is a flu season, as Dr. Chanda has mentioned, and we do have a system actually that is a surveillance system that is dedicated for surveillance for influenza influenza infections. And so we actually have the testing available, and we have a system that where we systematically and continuously and in routine mode do collect samples from different parts of this country to monitor for all influenza illnesses. We have this program has been running from as far back as 2007. So it's a very mature program. So as far as influenza is concerned, we have adequate capacity, and we actually do this continuously and routinely. So all the samples, for example, for people who are presenting with influenza like illnesses and symptoms, these are actually taken to the laboratory for testing, and we look out for influenza. And we do actually find it, and you'll be interested again to know that also the program has now matured to combine and integrate COVID testing. So we are actually testing all those that come out negative for COVID. We push the samples to test them for influenza, and we are actually finding influenza for that. And also the opposite, we are doing that. Those that come out negative for influenza, we also test them for COVID, and we have been finding positives from there. So we do have adequate capacity when it comes to respiratory illnesses surveillance, and there's actually this capacity has matured over time, and it is a surveillance system that is very robust and quite very strong.
Thank you very much, Mr. Panga, for that reassurance. And I want to take the opportunity to tell the public through our media personnel here that it is important to get to a healthcare facility anytime you have symptoms, so that we do determine what is really happening to you and ensure that you get the correct treatment and avoid severe disease. And more so, especially in people who are vulnerable because of the comorbidities that they suffer from, and even in children. Children distress very quickly, and so it's important that they're taken and dealt with in good time. I would like to say that we should be comfortable that today, COVID-19 is not really a death sentence, right? There are definitely ways of preventing the disease. We've tried to control the disease. As you saw over time, we haven't had so many cases. Remember, we went to below 1% positivity for quite a while. And so I'd like to believe that it doesn't need to be a death sentence. Allow me to talk to Dr. Dalao, our mental health specialist. Dr. Dalao, we used to sing, and sometimes still do sing, the song on the 5 golden rules. Do you want to talk about that? Do those still apply today?
Yes. Good morning to everyone, and thank you for having me here, Director Mazianga, and a very warm welcome to everyone who's joining us online. So the 5 golden rules. When we talk about the 5 golden rules, we're talking about face masks. We are talking about physical distancing. Physical distancing meaning that we have to stand or be in a certain distance, also 1 meter apart. We are talking about washing our hands, and we were not just saying washing our hands, but we were saying washing our hands with clean water and soap or hand sanitizer. And this was there was a lot of key messaging around that during the peaks of COVID. We were also talking about avoiding crowded places. And when we say crowded places, we are talking about places where there's high traffic of people, community spaces. And then finally, the fifth one was seeking medical attention if you are unwell and symptomatic. So the symptoms that Dr. Chanda spoke about. So these are the 5 golden rules. Now, where we are today, I would like to throw a word here, Silvia Lotayanga. It's been some time that we've been doing this. And do the 5 golden rules apply today? Yes, they do. They do when we talk about people that are symptomatic, individuals that are coming through and they are actually symptomatic, because when they're symptomatic, they're actually spreading the virus. And if they're spreading the virus, it means other people are probably going to pick it and more likely get ill. So who should mask up? Again, this is not something that is, forced onto people. This is more voluntary. However, if you are symptomatic and even in your homes, you should mask up so that you prevent the spread of the illness. If you are symptomatic and you are in a high public area, please do mask up because that will help prevent the spread of the virus further. Maintaining physical distancing, again, depends. It's more about if you have the symptoms and you have been tested positive, you have to make sure that you are actually not spreading that virus. So maintaining that distance is also important. Avoiding crowded places, again, if you've tested positive for COVID-19, it is advised that you avoid crowded places so that you do not spread this virus further. And again, seeking medical attention, this is as simple as it gets. If you have been exposed to COVID-19, you know someone that's tested COVID-19 positive, you don't necessarily have to go and test if you are not showing any symptoms. However, if you are showing symptoms where you feel like a cough, you feel like you sneeze, you have flu-like symptoms, in addition to that, you feel tired, you feel fatigued, please do go and get tested so that you are aware. That means that you are symptomatic for COVID-19 and you are spreading it. So to the 5 golden rules, those are very key. I've actually not spoken about one that is arguably, when it comes to infection prevention, very important is washing our hands frequently with soap and water. Again, when we say washing our hands, we don't just mean running our hands under water. We're talking about doing the right thing, because our hands are what often touch high contact surface areas, and we often infect ourselves and spread the virus more. So washing hands stands even today. If we are in a public area, if we're eating out, if we're doing anything, even in our homes, let's still promote hand hygiene because that is a very key golden rule for us to prevent the spread. Not just for COVID-19, as highlighted by Dr. Musonda, also other diseases. When you wash your hands, you are fighting away close to 70% of infectious diseases that can easily spread. We're talking about cholera, which is not something that is distant from us. We are still dealing with cholera in our country. Okay, we are talking about other infectious diseases that can easily be avoided. We are talking about typhoid. From time to time, we hear scares to say there's a typhoid outbreak. All of these can be prevented by washing our hands with soap and water. So that's the messaging even today, Madam Masianga, to say yes, the 5 golden rules stand. However, they are going to be applied depending on the symptoms and the presentation of individuals.
Thank you very much, Dr. Donau. So, some people say, no, this is a hoax, it's a way of government and the pharmacists and, the people in the public health sector to, get money out of, the population and so on and so forth, or to get funding and things like that. What's your take on that rumor? I would like to call it a rumor, but yeah, what's your take on it? Is this a hoax?
So, Madam Mazanga, and to all the media houses here, we are all human, okay? And we all have our own understanding levels, we all have our own exposure and experiences in life. And now more so because of the impact that COVID-19 has had in all our lives. Everyone has a COVID-19 story. Whether you've been infected, whether you've not been infected, whether you've lost a loved one, whether you've not lost a loved one, you've all been touched by COVID-19 in your reality, in your day-to-day lives. When COVID-19 hit, it really disrupted not just the health systems. We didn't just lose loved ones, but even our social factors, our socioeconomic lives have been uprooted by this pandemic. And so now, when we see that even today, why are we having this media cafe? It's COVID-19. Why haven't we had media cafes for other things? These are questions that are very normal to have. The points that you raised, last week, the Honorable Sylvia Masebo, Minister of Health, was in Parliament talking about the deaths on COVID-19. And social media was in uproar to say, up to today, we're talking about COVID-19. It's not real. It's fake. It's just a way for governments to get money. Donors are putting in money. They just want to get us vaccinated. Whatever is set in that vaccine. These are normal questions to have. However, Madam Majaga, I would like to guide all of us in this room and to all listening in. Question those questions to the people that you see here and the experts in our communities. Don't just communicate that on social media and let it go like wildfire. These are credible questions to have. Is COVID-19 a hoax? No, it is not. We have seen people die. We have lost loved ones. We have seen our own healthcare industry ravaged by COVID-19. We have lab surveillance systems that are showing that COVID-19 is real and is going through a lot of changes. The virus is mutating, as highlighted by Mr. Panga. So is COVID-19 a hoax? No, it's not. Is this the way of government getting money out of donors or sponsors? No, it is not. Mr. Panga already told us to say if we let our guard down, this virus is going to mutate. And if this virus mutates, it's going to end up causing more problems. And we may end up going back to where we were. So for us to be a step and prepared and be ready, we are going to constantly learn from the lessons of the pandemic so far and now move forward. Yes, there is that point from the World Health Organization that as of first week of May, COVID-19 is no longer a global health threat. But that does not mean that COVID ended. It simply means that we have it in a space where we are ahead of it. But it's not over. It is still with us.
Thank you very much, Dr. Dela. In the last 1 month, we, when this incidence of COVID has gone up, we've lost 2 people, and coincidentally of the same age, one female, the other one male, but both at age 83. Should we be concerned that, is it attacking the elderly more severely, or, is there an age thing to do with this COVID-19?
So this is where we talk about vulnerabilities in our communities as a country, as Zambia. We need to also focus on what our population is. And we do have a population, yes, majority of our people, Zambians, are young, but we also do have vulnerable populations. And in these vulnerable populations, we talk about the elderly. COVID-19 as a virus is known to affect individuals that are 50 and above more severe than those that are younger. Now, why is it that? Again, Dr. Duncan Chanda just spoke about comorbidities, and he explains that comorbidities are illnesses that individuals have that they are living with. Illnesses such as diabetes, illnesses such as high blood pressure, illnesses such as asthma, which is a respiratory illness, infectious illnesses such as HIV. We have that disease in our communities. Infections such as TB, tuberculosis, which is also in our communities. When we have these populations of individuals that are living with these illnesses, we have to improve our security for health for these particular populations. We can't just look away, including our elderly population. Our elderly population are actually a backbone of our society, the wisdom that they bring. I would like to just reference to HIV in the early era. We lost a generation to HIV because we couldn't have treatment in the 1990s. And with that era, we have a huge vacuum and gap of that population. And so, even now that we are losing this elderly population, we shouldn't just say it is the older people that are dying. It's okay. It is not okay. Fellow Zambians, for us, it is not okay because these are key population and they support our communities, the social fabric, the communities in a home, grandparents and parents actually are a backbone for support of health. When we talk about health, we're talking about physical well-being, social well-being, and mental well-being. Whenever we are stressed or overwhelmed, who do we go to? We go to the elderly in our communities. Whenever we have social issues or concerns in our communities, who do we go to? The elderly. So this communication to say, oh, it's just someone who was old and they died because of COVID-19, it was their time. No. COVID-19 is an illness. It is not normal for people to, in whatever age spectrum they are, to die of COVID-19. And this is why we are saying that we should support our vulnerable populations. And in our vulnerable populations, it's not just the elderly. We are also talking about individuals that have underlying illnesses that they are living with. People living with HIV, people living with TB, people living with asthma, people living with mental illnesses, people living with diabetes, hypertension. They are more prone to severe forms of COVID-19. And so we are supporting these vulnerable communities better. So when we see a mortality because of COVID-19 and they have an underlying health concern like hypertension, HIV, or TB, we shouldn't just say, after all, they were old. After all, they had this disease. We should be concerned because for that particular home or that particular community, that is a life lost. And that life is a social fabric that affects the whole community as a whole. Yes.
Thank you so much, Dr. Delao, for that important information. I'd like to speak to Malongo. Malongo, the sixth golden rule. Sometimes referred to in other circles as the golden bullet or the magic bullet, is vaccination. Do you think the use of vaccination has been a game changer in preventing and controlling COVID-19?
Thank you so much, Director, and I'm happy to be here today. And good morning to the other panelists and everyone online as well as in the room. Most definitely, I think that's a huge statement indeed. Vaccines have been a game changer, and I think I'll speak to what Dr. Delao has just said. So, next to the provision of clean water in terms of public health interventions, we have the number 2 intervention being actually vaccines. So globally, every year we prevent about 3 to 5 million deaths, prevented by vaccination. So we can definitely say that vaccines do play a huge role when it comes to our public health interventions. And of course, in terms of for COVID-19, we can see that over time we have seen a huge reduction in the number of cases, of course, from what we had when we just started vaccinating around 2021 and to date. So we have managed to vaccinate over 70% of our eligible population, and we can definitely see the impact this has had on the number of cases that we are reporting, even in what seems to be these waves that we are having over this period of time. And I think that's what was the biggest push to ensure that our populations are protected. And even with the advent of these other variants that are coming in, we still see that there's still protection that these vaccines are offering to our populations. So definitely, it has been a game changer.
It's nice to hear that, Malongo. So, last weekend on the golf course, I was chatting with some friends, and one of them isn't vaccinated, and then so I was trying to entice them to get vaccinated, especially that we have this resurgence. And they said, look, I've seen people who are vaccinated getting sick, so what's the point?
Definitely, that's always an argument that comes up. So what's the point? I received my vaccine, I'm fully vaccinated, I'm boosted even, I've received my booster doses, but here I am still, getting tested, and then of course it comes out positive. So what do vaccines really do? So that's what we need to ask ourselves. So to start with, vaccines basically just prepare the body for a response. So they prepare our body for a response that in the event that you do get infected with any disease, the body will be ready to mount a response against that disease. So it doesn't necessarily mean that you will not get infected, because the body has basically just provided now, the vaccines have provided a platform, so once that disease comes in, they are ready to go in and fight the infection. So that's the thing that we really have to remember, that what is the use of these vaccines? It's for the body to actually be prepared to mount a response, making sure that even if you do get infected, one, for example, for COVID-19, we have a reduction first in hospitalizations, and even in the intensity of what symptoms the person might present with, all those are reduced because, of course, the body is ready to fight that infection. And definitely, we've seen a reduction, of course, in the number of deaths. So these are all the functions of the vaccine. So I think that's the key message here. What do these vaccines actually do? They prepare our bodies that even in the event that you do get infected, get exposed to whatever bacterial or viral disease, your body is actually ready to mount a response against that disease, and in this case, COVID-19.
Thank you so much, Maluko, for that. And I suppose the stress is that even when we look at childhood immunizations and, with regards to vaccine-preventable diseases, the same applies.
Definitely, definitely. And thank you for bringing that up. Right now, we are in the Child Health Week, and we are actually giving, this is an integrated Child Health Week. So we are giving the BOPV, polio vaccination, and then we are also offering the other normal Child Health Week services. So that's your deworming, vitamin A supplementation, as well as growth monitoring. So it's very important here as media houses as well. I think this has been coming up as one of the key reasons that people are hesitating towards getting even our polio vaccines, that we've received too many vaccines, why do we continue to mount this response? So I'll just delve a bit and allow me to digress, Director, since you brought it up. Allow me to digress, so move into the polio space and see why are we really giving our children these multiple doses over time. This is us really trying to build herd immunity around this population. So apart from COVID-19, which I think Dr. Dalao mentioned, it's no longer a public health event of international concern. That's what WHO said. But we are still in the pandemic mode. Pandemic means basically that the disease has spread globally. So for what we have as polio is still a public health emergency, because we've seen cases of polio coming up. And it's one of those things where I think this generation, or I think a few of us in the room, I think apart from Dr. Chanda here and maybe someone from Radio Maria there, have probably seen cases of polio, and some of us have been privileged in our generation to not see that, and that has been largely because of the interventions that have been put towards eradicating polio, which is the vaccination, which is responding to having multiple doses administered to the population. And it's because also orally, I think maybe Dr. Chanda will also speak to that and how the vaccines work. We need to have multiple doses for the child to actually build sufficient immunity against polio. So I think just to speak to that as well, it's basically the reason why we continue to emphasize that next to clean water, next to washing hands, the cheapest, most cost-effective intervention against most of these public health diseases is actually getting yourself vaccinated.
Thank you very much, Malungo, for that piece of information. And having confirmed that vaccination is a game changer, especially in all vaccine-preventable diseases, but in this case we're talking about COVID-19, vaccines available for everybody is eligible.
Definitely. So we do have vaccines available in all our health facilities. So we have Johnson & Johnson that is readily available, our single-dose vaccine with eligibility for a booster. So that is after 2 months of receipt of your single dose. And then we have Pfizer and Sinopharm. And of course, you're eligible to receive a booster dose after 6 months of receiving your first 2 doses, which are given 4 weeks apart.
Thank you very much, Manongo. I'd like to go back to Dr. Chanda. One gets vaccinated, is vaccinated, fully vaccinated, but gets symptoms suggestive of COVID-19. Should they visit the healthcare facility? I'm vaccinated. I'm supposed to be protected.
Yeah. So yes, indeed. Even if one is vaccinated, right? Okay. Even if someone is vaccinated, they can still get what we call breakthrough infections, and this is not actually unique to COVID vaccination. There are a number of vaccines where this may happen. I'm glad when there was a question as to why are we going to vaccinate children to get sick. We get BCG vaccination at the time of birth in this country. If a child misses out on BCG, which protects against TB, and then later on in life, including adult life, if they develop TB, they actually get very severe TB, and in most cases they die. Okay, so from the beginning of the pandemic, my research group actually has been collecting data on various aspects. So the first thing we did, we mapped out on which kind of people are going to be at high risk for death. A year later, when the vaccines, after the population was vaccinated enough, we went back and analyzed the data. And in that data, we actually showed that if one was vaccinated and they still had all these comorbidities, there are a 70% chance that they're not going to be protected from death if they're actually admitted into hospital. Other studies which have followed people who are vaccinated and the possibility of being admitted have also demonstrated that those who are vaccinated are less likely to be admitted. If they're admitted, like in the case of our study, they are less likely to die. Okay, so in this RNA vaccine, one thing we have noted is this phenomenon of breakthrough infections, which tend to be much louder. And so one shouldn't be worried in that sense, but they should present and just confirm whether they have COVID or not. I should add that if you don't have any comorbidity, we haven't seen a case of those who are vaccinated actually get very sick, except those with comorbidities. And then there's a new concept, like every other disease, we would like to treat. Early in the epidemic, we didn't have any options. Oh, by the way, there was that madness of everyone taking azithromycin. I'm sure people took azithromycin here. Some took ivermectin and all sorts of things. And people are still taking azithromycin. Azithromycin is an antibiotic. It won't kill the virus. The reason we used it early in the disease is there was a side effect, a modulating effect to reduce inflammation that was tested just in one study, a very small study in France, which bigger studies later on disputed. So then we stopped recommending azithromycin, but even as I said that, I'm sure people are keeping azithromycin at home, which is just going to bring us to another problem, and microbial resistance. Okay, so what we are doing currently, we've got some oral antivirus. So you come in, vaccinated or not vaccinated, you have symptoms of COVID, you test positive for COVID. If we're classifying you as a high-risk person, usually those people with comorbidities, then we're going to give you antiretroviral called Paxlovid, which is just a combination of two drugs. Very tolerable drug, and what does it do? It actually stops the viral replication and also shortens the period of symptoms and reduces the chances of one getting admitted to hospital. And this antiretroviral is called Paxlovid. We have had it in Zambia for well over, we started the rollout plan in November last year. Yeah, so we have had it, I think, since late December. There are various health centers and hospitals where this is actually administered. Beyond Paxlovid, for severe cases, we have got various other antivirals or immunomodulators which we have in this country, which we give those who have moderate to severe disease. But for the mild disease, where someone can go home, we give you 5-day course of Paxlovid, and it's working well. I would encourage the press to take interest in this, and then also disseminate, I think, the lack of information around this antiviral, which has been repurposed actually for COVID-19. Yeah, so in a nutshell, whether you're vaccinated or not, when you have symptoms, you have to present to the health facility. We test, and then we check your index of risk for severity, and then we decide whether you need Paxlovid or just send you home. Sometimes people get frustrated just being sent home. Okay, go home for 3 days, or when the symptoms stop, go back for work. Okay. Yeah, thanks.
Thank you so much, Dr. Chanda. So is this what we're calling the test and treat?
Yes, so the test and treat. We got that concept from HIV, obviously. We knew once you suppress one who's infected, the disease progression is stopped, and that person is not going to transmit to the next person. So the same concept, if you are symptomatic, then you are at high risk. By the way, we would have loved to give everyone, but just look at the cost. How many cases did we have yesterday? 200 and something? Yeah. So So out of that 219, probably only about 15% would qualify for Paxlovid. The elderly, people with diabetes, hypertension, asthma, people with previous TB or current TB, people we have shown previously that these people are likely to end up in hospital, and if they end up in hospital, they're likely to die. Don't go and just have this other disease so that you get Paxlovid. Just keep it for those who are at high risk for progression. Yeah, thanks.
Thanks, Dr. Chanda. You know, even when the vaccines came, the concern was, are these, efficacious? Do they really make a difference in, the outcome in a person who suffered from a particular disease? And in this case, we're talking about COVID. So have studies been done to indicate that indeed this Paxlovid ensures a good outcome? And after that, you would also answer for me, how do we tell that, it has really worked? You've been given the treatment, taken orally, taken to go home, and, so you take it from home. You need to go back to the healthcare facility to ensure that you are responding to the Paxlovid.
Great. There's been COVID brought a lot of things. People came up with weird ideas on how vaccines and the drugs are approved, adopted by countries. People came up with stories, the pharmaceutical companies forcing us to get this without proof. That's not true. There's a very complicated way of getting any of these products to the market. And most countries like Zambia, we depend on the data from clinical trials and other observational research. And this data is really analyzed beyond the people actually produce the product. For instance, I sit on the WHO COVID-19 therapeutics guideline development committee. So we are constantly reviewing the data on any product someone claims it work. We have statisticians who thoroughly analyze that data, then present to us subject experts. So Paxlovid is one of those drugs that are approved. By the way, I think since we started that committee over slightly over 2 years, I think we have reviewed more than 35 products and I think approved less than 10. Yeah. So it's quite a rigorous way, and we normally approve, like for Paxlovid, the clinical trials were very obvious. People who took this actually had a shorter duration of disease and they didn't end up in hospital. Hence, when you see your country adopting some of these products, it's because they've been analyzed and found that actually meet the criteria set by WHO. Yeah, so yes, so Paxlovid is one of those. Coming to the vaccines, there is always a confusion as to what the company that produced the initial vaccine says the efficacy, which is usually very high, which is okay. It's because usually when they're doing the early experiment, they actually leave out people at very high risk. So it's a highly selected group. But when you come and apply, the reason we observe this, like the reason I'm doing these studies, is trying to compare the efficacy of what they found in the clinical trial and what we're seeing in the real world situation where there's a mix of population. So we still have demonstrated very high efficacy for such a new product, relatively new product. And we're still following up. Besides that, there's what we call pharmacovigilance, where we are monitoring side effects. Any drug and vaccine is going to have a side effect, and that we know. Some side effects are so mild, so people don't care about them. I mean, like I should mention, Paxlovid sometimes give you a mild diarrhea on day one. For some people, it gives them a metallic taste. Yeah. But most of people won't even report that. Yeah, you know what I mean? Yeah. And we have heard a lot of things about COVID vaccination and someone dropping dead that I've never seen. I've seen that very dramatic thing of putting a lot of different scenarios together. Yeah. You know that those anti-vaxxers have been anti-vaxxers for every vaccine that existed, and they try to push such an agenda. For Paxlovid in Zambia, what we are doing, once we give you, we don't expect you to come unless you deteriorate. So from our clinic, we haven't seen any. But on day 30, we are going to call you. There's a group which is monitoring. Then they're going to ask your experiences, if you had any side effects, and how you are at that point. So that's what we're currently doing. How many doses did we receive? Initially, we received doses, I think we plan to receive doses equivalent for 30,000 people. I'm not sure how much we have received up to this time. Yeah.
Okay. So definitely in the public sector, there is this eligibility that is considered before you get the Paxlovid. I was just wondering, if I walked into a pharmacy, are there any pharmacies that offer Paxlovid? Can I go and buy Paxlovid if I'm feeling vulnerable? Is that even the right thing to do?
I'm not sure if there is, but you know how pharmacists now that they've asked me that question, I'm going to ask some of my pharmacist colleagues, but that's not the right thing to do. I think you need medical advice before you take some of these antivirus. And please don't go and get Paxlovid and start piling it up in your houses. So that's when you just feel like it's not swallowing. Yeah, those are some of the risks with oral drugs. Yeah.
Thank you so much, Dr. Chanda. That was so interesting to hear. I think, Dalawa, you had something to say?
Yes. So with respect to Paxlovid being in pharmacies, no, right now pharmacies do not have Paxlovid. All the Paxlovid, as Dr. Chanda has guided, is currently in health facilities. All provincial health facilities have a COVID-19 clinic. So we have that robust network in all provinces. And these are the sites where Paxlovid is being prescribed. As we've guided, this is a medication that we're giving as and when we screen and we deem you eligible to get it. Again, another point that I'd like to mention is that it is not for sale. So this is why no pharmacy is going to sell Paxlovid to you. In addition to that, Madam Mazianga, I would also like to communicate that this is also undergoing the implementation rollout study, right? So people should not be saying, "Oh, we are being used as people to check if this is working or not." No, no, that's not the case. It's just to show, because many times whenever we get these medications, we often say, "Oh no, this was something that was just done by the Western world and it hasn't been tested amongst our people. This is what we are doing. We have eligible researchers in our country, so we are doing that and finding out what is working and what is not working." And Zambia, through its network, is actually one of the few countries on the continent that is offering this service. So we do have this treatment. We have what we call test and treat. So please go to a COVID-19 clinic, get yourself tested, screened, and then get that medication, and we will see how we go from there. In addition, Madam Osama, this is also in private sector. It is not just in the government sector. So in all provinces, private health facilities also have Paxlovid. Just the way we have the HIV system and antiretroviral medication in the private sector as well, is the same way we have Paxlovid in the private sector as well. So it is not for sale. Thank you.
Thank you so much.
Let me mention something. Just mention the issue of people saying I've been used as English. At the international level, we have a different argument as researchers. So pharmaceutical companies don't want to come to Africa to do early stage studies. They say it's costly for them. They don't trust our ability to carry out those tests. The reason we insist at one early stage investigations here is to look at the safety in our own populations. But you see, they're not interested in coming here. They remain in the USA and do the early stage studies, usually heavily skewed in the Caucasian population. And then they do level, what do you call them? Level 3 clinical trials. Again, they do them in the US. Again, heavily skewed in a white population. So they do all these things and get their approvals in Europe and in the USA. And then they bring the product here. The product is, we have a different genome makeup. Like we learned a lot on ABC, one of the antiretroviral drugs. Okay, we tended to
Antiretroviral for HIV.
Yes, so because of this different genetic makeup, people interpreted so many things which we are seeing in the Caucasian cohort that it will happen in the African cohort. So in the Caucasian cohort, there are a very high level of hypersensitivity reaction. We don't have that. We actually don't test for that. In the Caucasian cohort, they have to test it now in the US. Part of it has fallen off favor. So it's funny that our people, social media, get this idea that we are being used as the guinea pigs in Africa. Far from it. It's a very rare occasion, actually. That we do phase 1 or phase 2 trials. I've only managed to do phase 2 trials here. So, and that puts the scientific community in this side of the world at a very, the scientific community at a disadvantage, the population at a disadvantage. Yeah, so people should appreciate when we're trying to actually test this in our own population, that we're trying to actually protect our population. During the research, the amount of pharmacovigilance we apply is so rigid that any side effects are picked much earlier. As for Paxlovid, I think we're only 3 countries that have access: Nigeria, Zambia, and maybe Botswana or South Africa, one of those. Yeah, so yeah, just that clarification about the guinea pigs. I challenge colleagues from the press to actually read around how these things are done and understand phase 1 to phase 4 trials. By the time these drugs are coming to Africa, it's phase 3 or phase 4, meaning all the safety data for those other populations have been gathered, and you make the same assumption that in Africa it's the same profile, which is not usually the case. Thank you.
Thank you so much, Dr. Chanda, for filling up with us with that knowledge. You know, it just reminds me of what the president keeps saying to us, the scientific community. He keeps emphasizing that we need to enrich our own information. We need to understand, you know, our population and generate, you know, solutions, therapeutics, diagnostics, and so on that are suitable to our facilities. But I think that's a story for another day. And so, you know, maybe we push that discussion to another day. We talked about azithromycin, Dr. Chanda, and how many of us have azithromycin in our you know, medicine you know, cupboards and so on and so forth, and yet you know, we, on the other hand, we have our colleagues, and we are part of that group of people who want to know about antimicrobial resistance. I wish to talk to Mr. Mpanga. You know, there's a very bad or indiscriminate use of azithromycin and many other antibiotics, especially during this COVID. You know, people take, you know, if you're not responding to, you know, azithromycin, go and get amoxicillin. Oh no, you know, there's a lot of street medicine with regards to antibiotics. Mr. Manga, tell us about antimicrobial antibiotic resistance with regards to COVID-19. Should we be concerned?
Thank you very much. So, yes, indeed, we must be concerned because the issue of resistance, the number one, you know, cause and driver for resistance is actually misuse of these antibiotics or medicines in general. And the famous medicine cupboards in our homes, I think we must not even have these medicine cupboards in our home, because the medicines, or when we are prescribed, we go to the facility and the doctors give us these medications. They are meant for a specific illness and for a specific person for a specific period. So they will always tell us, this, you know, package of drugs we've given you take one in the morning, one in the afternoon, one as guided. And you take it for 3 days, 5 days as prescribed. And so when that period that you've given us to take, you know, if it is 5 days elapses, we must even, you know, by that time, obviously, either the pack will be empty, or if there's any, you know, remainders, maybe because you have missed a dose, because that's the reason why you would have anything remaining. But essentially, the medicine should finish. So we actually must not even have a place where we keep medicines. No, because we are not to keep these medicines. When they were given the course that's prescribed to us, it's for that particular purpose and duration, and we must get rid of it. Now, what usually happens is that because of, you know, these famous medicine cupboards, we find ourselves not finishing the course. Once we feel better, we stop and we walk away and pile up the medicines. And next time we feel, you know, the same or not feel well, we go back to these medicines, which is a very bad practice and a contributor to resistance. So this resistance basically is emanating from, you know, we are the ones contributing to its, you know, emergence and increase. But in itself, it is a phenomenon, you know, for the bacteria, you know, the viruses, the parasites, and all these pathogens, like I mentioned, for them to survive. So they also want to live, in as much as we are using the medicines to treat them. So if you get your medication, take half course, because remember, any time that, you know, our experts have given you medicines, they have measured that amount of medicines they've given you is enough to kill the particular agent that you are infected with. So if you don't finish, it means that part of, if you can quantify the infection or the bacteria that you have, is going to reduce to maybe about half, because you've only taken half the dose. And therefore, the other half of the germs remaining still in your body have now gotten the knowledge that our colleague here was talking about vaccine making your body know about this particular infection. So even the bacteria or whatever germ you have in your body also gets to know that, oh, there's actually azithromycin. What do I do for me to survive? Okay, let me change in this way, which is the famous mutations we're talking about. And hence, the bacteria or the virus mutates. And once it mutates, so that it can survive in that environment for azithromycin, as you have asked, for example, here, then it means the next time you will take azithromycin, this bacteria or this germ already knows how to defend itself against the action of azithromycin. And that is where the resistance is coming from. Our bad practices of not using the medicines correctly, taking the right medicine for the right illness, taking the right medicine at the right time for the right dosage that you have been given. And the abuse that has happened during the COVID pandemic has really, really put us in a lot of trouble, especially with the particular medicines like azithromycin that we have abused. And right now, Dr. Sanda would confirm that the only illness that will be given azithromycin, if I'm not mistaken, Dr. Sanda, one of them is Vibrio, is cholera. We use the azithromycin actually to treat cholera. So next time you because of the lot of azithromycin that we've taken, and any cholera that we might be having already knows how to defend itself against azithromycin. So when you get sick, be guaranteed that azithromycin won't work for cholera. And I'm sure we all know how deadly cholera will be. And obviously then the only medicine that we had in this case, which is azithromycin, we could have used to treat the cholera, is already aware of it and can already defend itself by mutating and being resistant to it. So these are actually very bad practices, actually making us run out of options to actually use for the treatment when you now get the right, is it the right gem for the right medicine, if there's anything like that. Yes, and then you find that you've got the right medicine here, and you've got the right, you are infected with the right gem, but the right medicine can't work. So it is a very, very bad practice and really, really a threat to our health. And we must, and I urge your colleagues here for the media especially, to get on this campaign and champion and make our voices louder, to encourage our people out there to follow strict instructions that are given by health experts, and all the time make sure we consult with the health experts that about the illnesses that we have.
Thank you so much, Mr. Mpanga. We talked about issues of concerns around being contact to somebody with COVID-19 and so on and so forth. And so there are also sometimes people who decide, oh, let me just get tested because I was sitting next to Mpanga and he has COVID. And then I test positive, but I'm asymptomatic. Should we be concerned about people who may be infected with the virus but are not displaying any symptoms? Especially within the family setup, should we isolate a person who has COVID-19, even if they don't have symptoms? Should we get tested because we know they have COVID even if they don't have symptoms? Dr. Delao.
Okay, so for that one, colleagues, here the point is that COVID is going to be with us. It's a virus, and it is one of those viruses that is going to stay with us. Just like we have the common cold, the influenza, it's seasonal at times. Whenever the cold season is there, it tends to Same thing with COVID-19. If you have a contact, for instance, right now, there is an increase in COVID-19 cases. We've already discussed that COVID never went. COVID has always been with us. However, now that the seasons have changed, the virus is not mutating, spreading quicker. Why is it spreading quicker? Because it's the winter period. And if I'm going to arguably ask people to say, how frequent do you wash your hands in the winter? People are going to say, not as often, because it's cold. How often do you maintain hygiene in the winter period? You probably wear the same coat every other day. Okay, so the spread of the virus is also there. Now the question of, if I have COVID-19, I am asymptomatic, should I, isolate? There's no need to isolate really, but do you practice the golden rules? Yes. Make sure you constantly wash your hands with soap and water if you're COVID-19 positive. Make sure that you're putting on a face mask so that you don't spread the virus as much. Make sure you maintain you avoid high traffic areas. You are COVID-19 positive, you've tested positive, but you are symptomatic, and then you're going to a high traffic supermarket, or you are using spaces where you are touching all these things. This is going to spread the virus. So taking upon yourself to maintain that preventive hygiene measures. In addition to that, if you know someone at home who is COVID-19 positive, maintain those preventive measures at home within your spaces. However, if you have someone at home or in your space who is vulnerable, when I say vulnerable, I'm talking about anyone who is above the ages of 50. We're talking about people that have comorbidities like hypertension, blood pressure, HIV, TB. Make sure you protect them by making sure that you are not spreading it easily to them. And if it does go to them, make sure, even if they are asymptomatic, they get tested so that they are put on the test and treat regimen. So this is where we're saying, should we have quarantine or isolation centers in our homes? No, we should not. But should we have preventive measures in our homes? Yes, we should. So this is what we are doing now. Not that we are going to start coming to people's homes or to police people, but we are requesting people to maintain these golden rules, which is wash your hands with soap and water, put on a face mask if you are symptomatic, and also if you have vulnerable people in your space, in your network, in your communities, make sure they are supported. And finally, the sixth golden rule, vaccination. If you are not boosted, please make sure you get boosted. If you have vulnerable people in your community, make sure you take them for the vaccination so that they can be protected.
Thank you so much, Dr. Galao. That's very, very important and critical information. Let's be concerned, let's be caregivers, let's be concerned about the people who are with us, especially those who are vulnerable. Madam, a number of children, since we started vaccinating 2 years ago now, right? A number of children have turned 12, including my son. I have a son in the recent past. Should we get them vaccinated? There's now the test and treat, so that so forth. So should we bother really vaccinating these children who just turned 12? How important is that?
Thank you, Director, for that question. Most definitely. So the immediate answer to that is yes, we should get them vaccinated. I think I'll ask Dr. Chanda to further speak to the cases that we've had in the below 18 population. And I think that's just part of us trying to ensure that we widen the number of people who are receiving this vaccine to try and create herd immunity. And herd immunity is largely for those who can't receive the vaccine for different reasons. So not everyone, and I must mention, one, vaccines are not mandatory. Two, vaccines, there's some people who can't receive vaccines, whether at a certain point in time they may be ill, okay? So others have allergic reactions, so they are unable to receive a vaccine at a certain point in time. So the whole point of us, the healthy population, getting vaccinated is to ensure that we also try and protect, build a circle around those who also can't receive a vaccine for one reason or the other. So it's definitely that we should get vaccinated and have that population vaccinated. So again, I'll take this opportunity to also speak to issues of, for example, HPV vaccination for our 14 and 15-year-olds. So even in this current Child Health Week, we are also targeting the 15-year-olds who have received their dose of HPV vaccine, and we are also emphasizing that let's have this population also vaccinated against cervical cancer. I think the media, we need to do a bit more work around publicizing the need for actually HPV vaccination for this age group, and that's for our girls. So it's really key. And whether we should go ahead with this because there's now test and treat available, I mean, the media, we really need to come back and push the issue of prevention is better and is cheaper than cure. I think this should be the key message we should leave this media cafe with, and really go and disseminate to the public. You know, just because we have treatment options available does not mean we shouldn't take the much needed necessary steps to actually prevent any disease. So we've got, and I mean, that's the cheapest option we have. You know, when we come to treatment, already Dr. Chanda was talking about issues of the cost. It's not everyone, you know, who will be eligible to actually receive the antivirals, and these often come at a cost, you know. So what are the cheaper options then that we can you know, go for, and the immediate steps that we can take at an individual level, and of course at a public health level, to ensure that the larger population is protected, so that we don't even get to a state where someone has to go and get treated. You know, because again, treatment is also dependent on an individual. The time that they present at the health facility, you know, it may be too late. So we really can't say because we have this test and treat option, you know, I can just sit back and say I want to get vaccinated. So I think, Director, that's really the gist of it.
Thank you very much. I'll go to Mr. Mpanga. Mr. Mpanga, I just wanted you to emphasize, you know, the policy on testing. We did talk about, you know, the need to get tested and so on and so forth. And then, as you speak into that, could you also just brief us on how accessible testing is? Where should people go to get tested? And then we've also heard that there's actually a self-testing kit available. Is that publicly available? Can I walk anywhere and say, I would like to have a self-test kit for COVID? And, you know, how does that work?
Right. Thank you so much. So, in terms of the policy guidance so far for testing, let me make mention here that we are not doing what you would famously call the mass testing, you know, strategy at the moment. So our testing is focused on those who present, you know, with symptoms for COVID. Are they the only ones we are testing at the moment? We are also not testing the contacts, you know, the contact tracing and all that. So we are not testing. So our testing is currently restricted to those who have symptoms and do present with symptoms to the facility. And in terms of, you know, testing, like I mentioned earlier, the testing services are available in all health centers, all our health facilities, and obviously these are offered for free. Most of the facilities, if all of them do actually have even the rapid testing, so you will get your results, you know, almost immediately when the testing is done. And, you know, in line with the Ministry of Health, you know, vision and mission of ensuring we provide healthcare services to as close to the people as possible, the government is actually soon will be rolling out, like you mentioned, a self, you know, testing for COVID-19. And so what this will entail is that we will have places, you know, where when you go to particular these facilities that will be advised, you will actually get a testing kit, which basically would be a rapid test kit, a strip with, you know, small liquids in there. I want to put it very, very simple. Yeah. So you get a strip, and then like a pregnancy test. Oh yeah, like a pregnancy test.
Except you won't be using urine, right?
No. So you will then be, asked to, swab yourself in the nose or in the mouth, and then you will put that, and will be given instructions on how to do this, and you will, get to know, whether you have COVID or not by yourself within the comfort of your home. And there will be obviously a requirement then that for those, who are positive, then you will be followed up, and linked to care, evaluated whether you need, Paxlovid and so on, whether we need to manage you accordingly. So this is, in line to bring the health services, as close to the people as possible. So we will be rolling out this very soon, and we will be providing this for all of people out there to go and test for themselves. And at any time when you don't feel well, you just pull out this in your handbag or in your what's name? It's a backpack. It's in your backpack, and you test yourself, and we follow you up for a result. We tell you, okay, you tell us no, it was negative, and it was positive. And so this is where we're going. And like I mentioned, in terms of testing, so for the moment, we're not doing any mass testing. And so only when you have flu, it's been discussed here that it's a flu season. So obviously, symptoms of flu and all will be so much common. So basically, just walk into any facility, ask that you are tested, and you will be tested. And if you have COVID, you'll be linked to care. If not, and you will still be managed accordingly. Thank you.
Thank you so much, Mr. Panga. We're now coming towards the end of our discussion. It's been very interesting, and I'm very glad that we did have good media presence here, and I hope that they feel as happy as I do with the discussions that we've had today. Malungo, in one sentence, give me a take-home message on why people should be vaccinated. Just one sentence.
Okay, you're limiting me, Director. Given so much we have to say that, and this is Child Health Week.
Exactly.
Are you sure? Just a sentence. Okay. So, take-home message. I think I already emphasized this. Prevention is better than cure. I think for the media that we are addressing today, I think that should be a key headline, and really that's where we see a lot of these cases coming down. So prevention is better than cure.
Mr. Panda, your one sentence?
My one sentence, go get tested. Is that a sentence?
It's a sentence.
Yeah, so when you don't feel well, go and get tested. And we will soon provide means for you testing yourself. But for now, please go to any health facility and get tested for COVID. Thank you.
Thank you so much, Dr. Chanda, who I think should be a professor by now. You're the most senior scientist among us here today. I would like you to give us a wrap-up.
Yes.
What is the take-home message in terms of what we've discussed today? What should the media be focusing on?
Yeah, so let me, thank you very much. Let me put it in context. The epidemic, the pandemic evolved. The virus evolved. Our guidelines evolved. There is no need for confusion on that. The first time we had a case on the 23rd of March, that should be, or 18th of March, 18th of March, had just come from Brazzaville for training for COVID response a day before, not a week before. And our first guidelines, if you remember, we basically admitted everyone who tested positive. So the first case I went to see at the isolation center somewhere there in Chilanga, I was so impressed by one thing. They were well, they were walking around, and then I thought, like, then I was so scared of the disease. You should have seen the way I was dressed and the distance I kept. Then within a week, we moved them to Levy. And within a week, Levy was full with people who are not very sick. But because we didn't know what we were dealing with, we admitted people who are okay. Later on, we realized among these people that high risk people who are dying, but we are doing the whole round on 90% of people who are normal. Actually, even administering everything we are giving in those days. Then we learned quickly, and then we stopped that. We said, let them be quarantined from home, and we concentrated on those who are likely to progress and die. And everything else has been a history. So we've been changing. The pandemic evolved. Our reasoning evolved. The virus keeps on evolving. What is important is get the advice correct, okay, from your healthcare worker. Prevention is still very important, like any other disease. No healthcare worker wants to see you admitted. It's not something we enjoy to do. It's our job to get people back to their functional status. But if we can prevent that, that's much better. So let's prevent this by all the means we have. Vaccination, the 5+1 golden rules. And if you feel unwell, if you have symptoms, please present for testing. And we are going to give the appropriate advice. Let's avoid social media advice or Google advice, and then we find ourselves in problems. So prevention, the 5+1 golden rules, and early presentation when you have symptoms. That will be my closing remarks. Thank you very much.
Thank you very much, Dr. Chanda. This has been a very exciting panel discussion. I'm sure you agree with me. Do you?
Yeah.
May I have some hands? Yeah. So we will now go into a Q&A, but because the tea has already been served, I request that we have a working tea. And so just grab the tea and come back to your table, and then we can have a Q&A.